Finally, I invite Professor KPS Malik, the master of SICS surgery. And as you all know that he is called the father of SICS in India. And I learned all my techniques from him. And I produced my book before he could. so so he says that you are very, very great learner in that sense. So now we have, he'll be speaking first on secondary IOL and then on phaco-trab, which is the topic of Dr. Richu Goyal. Professor KPS Malik is a very, very down-to-earth person and loves us all and keeps on praising us. Although he is such a big shot, he has been president of AIOS, professor and head of ophthalmology at Safdarjung, professor and head at Meerut, Subharti Medical College, and then AIMS Rishikesh. So he is a great pioneer and a living legend with us. Professor Malik, sir, please.
लोड किया हुआ उसमें यार. शुरू ले वापस ले जाओ. यहाँ से फुल स्क्रीन कर लो. यहाँ से मारो ना. इसको क्या करना? So secondary IOL is one topic really that we need to do that many times, but most people I believe that it is not easy really. And secondary IOLs which have been in the vogue even now also, that somebody's, and why you need secondary IOL is there are many patients like operated for ICC and then they come for another eye has been operated for IOL, then this eye we do it, then traumatic aphakias, and there are many patients like during phaco or SICS that you drop the nucleus, tear the capsules and all. So you need to do the secondary IOL. And secondary IOL techniques are many, but secondary IOL, which I do believe is the solid, robust and life-lasting, that not in iris, if you clip the lenses either anterior or posterior, iris tissue is not good enough or strong enough to hold the lens for life. I have seen the lens in a child clipped in a traumatic cataract of a young child in anterior chamber, iris clip lens, and then found that one hand of it gave it and it was rubbing the cornea, and cornea became like bad, and of course the lens was to be removed and secondary IOL had to be done. So I'm talking of secondary IOL, which is scleral fixation, and there are so many methods. You might have read that you can do the scleral fixation within the eye, without scleral fixation, without making the sclera opening and all that. But I believe that this one is, my method is strong, and so this is basically that you make a scleral flaps 180 degree apart. You can do at 2 o'clock to 8 o'clock, you can do 9 and 3 o'clock, and you make the mark there, and then flaps should be good enough, big enough, not the just minor flaps. You see, this might go to up to 3-4 millimeters behind, and then you cut it from limbus and dissect it. So you have to dissect the sclera like lamellar dissection, that you have the scleral bed and a flap lifted from the sclera 180 degree apart. And when tension is good enough now, low tension, you can't dissect the incision. So I will dissect the superior incision area also without entering the IOL. And then the docking of one side, you have a needle with 9-0 nylon, Prolene, nylon, and both can be done, but I use Prolene with it. And then another side is 26 gauge needle. So this needles also you can bend it according to if you are doing it from nasal side, and temporal side is mostly the needle with thread. And then you have these lenses with eyelets. Lots of them are available with eyelet in both the haptics, and right here you suture our suture has gone straight and then bring out and we cut it. So one is go to the upper loop will go to the left and lower loop will go to the right. So this side, like 3 o'clock will get upper loop and 9 o'clock will get the lower loop. And if need be, the air is showing very well, I might have done the vitrectomy. And if need be, after putting the lens also, if you find the vitreous around, you can do the vitrectomy. And then these sutures are pulled, which have been, and these knots have to be many knots in the eyelets of the IOLs so that they don't slip. And of course, I have done it in a routine. And see now, this is anchoring knot, I call it. That the one long thread which is tied with the IOL, but this anchoring is near it, a knot made by a curved needle. So you get the sutures which has long needle and another one is a curved end. So curved needle and long needle in same sutures are available. So this anchoring suture is near the long suture which is holding the lens. So I can tie it with it. That means the lens of haptic is tied with the anchored suture. Now this flap was the posing problem and knots were extruding out. So I devised that I put the one suture behind the flap. So I take one suture, last suture behind the flap, so that flap sits back onto the knot we have created. So this would never expose, never have a chance of endophthalmitis. And most problems of the secondary IOLs were endophthalmitis in Western literature a long time. But this one, anchoring knot on the scleral bed, and the same knot, one thread has been tied with the thread which is holding the lens loop, and last was the behind the flap. So that was, and these patients, these flaps are so well covering the knots. This is another patient. Sometimes nasal side, these small needles are a problem to go into it. So you can break the needle and make it little bent also. So purpose is just to dock it. Needle from that side is long one. That is all right, you can take up to the here. But this needle, 6 o'clock, the 26 gauge needle, sometimes difficult near the nose to manipulate. So you can kind of break its hub and little bit, I have seen that it can get into the ciliary body and it can get in front of the iris. So you have to be careful seeing that. Ciliary body bleedings, little bit like this, you inject the air and it will stop, and then clots there in the last, you can remove the clots also. So massive bleeding you will never get unless you have really inserted into the ciliary body. Then same place, the upper loop and lower loop, and they were put and tied and then taken up. And we can use even a normal PMMA lens if you don't have the eyelet wala lens, and you can tie it in its arm and you can cauterize the end of the loops so that it doesn't slip. It will become bulbous by little cautery. This is single loop fixation, that is iris On the 6 o'clock, there was a capsule. You can see little whitish there. So you separate it from the iris by injecting visco between iris and a lower side capsule, and then you tie only upper loop. So upper loop you take behind the iris near the root and then out. So that loop will go behind the iris and not in front of the iris. So technique is right go behind the iris near the root and bring out this suture here. And then this suture in itself has to be twice tied. There are no suture, no second suture, single suture only. This one of course will go with the, so one suture is lying, another I gave the knot, another knot, and it is tied itself. So if you cut it, there won't be 4 ends, there will be 3 ends through this suture. There will be 3 ends to this suture, not 4. And if the iris is to be formed, you can pass the McLean suture through, and if there is a iodectomy, the iris has to be made again, pupil has to be made, you can do that. It's an easy one, going from one side of iris, then iris and on limbus, and then you can bring out and tie them. So iris, the pupil can be made out, pupil can be constructed easily. I had once a chance that I did something, I was taking a lens out with a virus vectis and a cutter, and wire vectis caught the 6 o'clock iris, and I pulled it in hurry and whole iris came. Whole iris means 100% iris came, and that also you can manage. You should not think of it as just bundle of little iris pigment. You can spread it, you can find this is the whole iris and put it in the chamber and make scleral flap 2-3 places, 9 o'clock places, and put the sutures, and you can tie the iris, and you can still make a pupil with a completely torn iris. Completely torn iris can be replaced. That complications you might have, I don't know, got it or not. I got it once and managed it that way. I used to get many complications because I was doing too many surgeries. Thank you so much. And next, again, one more topic of Dr. Ruchi Goyal I have to speak. देखना बेटा इसको ढूंढना जरा.
सर अगर आप पहले बोलते तो पहले ही भीड़ काफ़ी इकट्ठा हो जाती. अगर आप पहले बोलते तो पहले ही भीड़ बहुत आ जाती.
That's the note. That is a compliment, and I'm, sir, thankful for that. My beard generally comes on SICS. Yes. Yes, this one. I'm such a advocate of SICS that, like you have one doctor in Pune who doesn't call it small incision cataract surgery, he calls it smart incision surgery. And he charged more than FECO for it. So combined means generally in our country that doing the separate trabeculectomy and then cataract surgery, or the cataract surgery first, then trabeculectomy. So many opinion about that. If you have to do trabeculectomy and cataract, though so many will say that you do the trabeculectomy first and then do the FECO, or do the trabeculectomy first and then do the SICS. And vice versa. But generally, I would do in one go, whether I do FECO or do SICS, that they can be combined very well, and you can save the 2 surgeries and 2 problems for the patient. You can use the mitomycin, and mitomycin, don't use what is written in the books, use the very, very diluted mitomycin, and if you use it long area of the conjunctiva, then blab will be flat, flat. It would not be blab would not be balloon-like on 12 o'clock. So your mitomycin should spread in long area of the, under the conjunctiva, on the sclera. So IOL has been placed. And then this is a triangular flap. Generally, I make quadrangular flap. And this technique of cutting 2 pillars vertically and not making any punch hole by any punch. One parallel, and this is Dr. Ruchi's innovation. She did this, and then I also started doing that. But I generally make the quadrangular big flap for the trabeculectomy. Again, because that will make a blab which is flat, spread out over long area, and not prone for infections like a thin blab. So it won't never be a thin blab. And iodectomy has been done, and then of course you can suture the flap. And these side sutures you can use to stabilize the eyeball or expose the area where you want. So this is your mind, that I want to do squint, like in squint we turn the eye to one side, then to this side. Same way anywhere you want to do any surgery and the eye looks like, fornices look narrow, so you can put a suture on limbus to turn the eyeball anywhere you want. So like this has been to expose the upper part, the possibly lids and upper fornix was very shallow. So get this area, I had to put a suture to pull down the eyeball. And then of course conjunctiva can be, generally I suture the conjunctiva continuous, or you can do the interrupted also. But sutures, generally we don't leave this flap unsutured. Fornix-based flap for the trabeculectomy should not be left unsutured. So this is all for today's our session. Nothing else is remaining. And any of you can have the questions from these gentlemen. We have 5-10 minutes to ask any query about the surgeries we showed you, SIC, TRABI, and this is another of the surgery which I labeled as a flying eagle incision. There is a curve, there is a middle quadrangle, and then curve. So this looks like a flying eagle. So this is flying eagle incision. Again, came to my mind someday. Looks like a flying eagle. And then of course rest is same trabeculectomy like we did it. You do the rhexis, and I generally these days do the bilateral rhexis, means bimanual. I take 2 openings on the limbus. One side I have a needle, another side I have a dialer to guide the rhexis. So rhexis can be controlled if you use the bimanual rhexis. The nucleus is coming, and this is called assisted nucleus. It's a big brown nucleus, and you can do the bimanual irrigation by your phaco things, or you can use the iris AC maintainer one side and simple suction needle from another side. Lens can be injected, and trabeculectomy sutures. Like in the last time, trabeculectomy, like we are not cutting holes now with any of the punch. We are cutting straight parallel lines and then cutting that area and doing iodectomy. And flap, this one flap here is again to not that big which I want. I want a bigger flap of the trabeculectomy so that you get a bleb which is spread out. And it looks beautiful, and it never will make a. So thank you very much. I think we have done our time. This is a patient with trabeculectomy already has been done, and we are doing the cataract. Thank you very much. Thank you so much.
Thank you, Professor Malik, for a
इनमें से
wonderful.
किसी कोई रैगिंग करना चाहें आप तो you can do that, any of you.
नहीं, ये रैगिंग